Hello, everybody. Welcome to the global classroom of studies in surgery. Today, we are going to be doing Whipple resection. This is entirely surgical. It's entirely what we do in the operating room. And obviously, it's going to be more interesting, perhaps more useful for those of you who are surgeons or preparing to be surgeons. For the others, I think this is useful because this was once regarded as the most formidable undertaking in surgery. And even today, it can be. So it's a good idea to understand it and to get an idea about how complexity is best managed. I am Dr. Philip Thomas. I'm a general surgeon specialized in liver, biliary, pancreatic surgery, and transplant. As you can see, I've had a long journey in medical education, teaching medical students, nursing students, and residents in surgery, both in India and in the US, where I currently live. The objectives of today's talk are going to be, very simply put, everything you ever wanted to know about Whipple resection but were afraid to ask. I'm going to focus on how to prepare these patients for this big operation because most of them are going to be elderly and some are going to be quite frail. I'm going to discuss the management of a pancreatic fistula or a breakdown in the pancreatic anastomosis because this is the number one killer complication of this operation, and I'm going to focus on this complication to the exclusion of other relatively less complicated issues that can happen after this operation. Lastly, I'm going to address the issue of high volume centers and how there has been a trend by insurance companies to centralize these patients or drive them all to certain centers. And I'm going to try and break down for you what actually constitutes quality that a high volume center can deliver. And personally, I believe that that quality can be delivered even in so-called low volume centers. A little bit about the history of this operation. The operation was described by Alan Oldfather Whipple. And this is a person who was born in Iran and then moved back to the US with his parents to study in medical school in Princeton, which he graduated at the age of 27. He was 54 years old when he actually described this operation, and he retired at the age of 65. So he really only did this operation for about 11 years, and he performed nearly 40 Whipple resections or pancreaticoduodenectomies, as they are otherwise called. So he was probably doing only 4 operations per year until he stopped operating. He died at the age of 80 or 82, and by this time he must have had the pleasure of seeing his operation accepted, practiced, and perfected, not just in the US, but all over the world. That is the brilliance of his contribution. It's also useful to remember that he and others of his generation who achieved success with this operation did so without ERCP, without ultrasound, without CT scan, without tissue diagnosis. And their surgery was done with materials that are far inferior to what we have today. All their anastomoses were done with catgut and silk. And when I was a resident starting out in India, that's what we used when doing a Whipple resection in the early 80s. You will hear a lot of names associated with Whipple resection. The name of Longmire, Traverso, John Cameron, of course. But for me, these two individuals are really the names to know. Michael Trede, who was a German surgeon working in the University of Heidelberg, and John Howard, who was working in Toledo, Ohio. John Howard described 40 consecutive Whipple resections without a mortality. And around the same time, Michael Trede in Germany published 100 consecutive Whipple operations without a mortality. Reading these papers gave me a lot of confidence this was a doable operation and that success could be achieved by doing this. This was, of course, the number one operation which you could perform for patients with carcinoma of the head of the pancreas, which had any hope of achieving a cure or any hope of achieving good palliation. What I would like to draw your attention to, if you read these papers, is the fact that even at that point in time, they did not require proof of malignancy to undertake this operation. In fact, this operation was described for chronic pancreatitis, especially that variant of chronic pancreatitis called groove pancreatitis, which happens in the groove of the duodenum, where the head of the pancreas and the bile duct are situated, so that chronic pancreatitis in this area will involve the lower end of the bile duct, causing obstructive jaundice. And it may be a small mass lesion, which is impossible to differentiate from pancreatic cancer even today with all of our fancy endoscopic and needle aspiration techniques. How have these pioneers impacted the management of pancreatic cancer? When you get into this question, things get very murky. And I would like to draw your attention to this paper published in the Annals of Surgery in 2007 by Billimoria et al., which was the first paper at the time to address this issue of underutilization of Whipple resection in patients with carcinoma of the head of the pancreas. They reported that over 50% of patients with T1, N0, M0 lesions, which are curative by definition, never get a Whipple resection. Only 35% of patients with locoregional disease, in whom you may be able to get a cure, but certainly you can get the best palliation from this operation, never get this operation offered. I would encourage you to look at this paper. It was published in Annals of Surgery, and the editorial in that volume was devoted to this issue. There was never an article of this nature published before this, and I have searched the literature and not found an article after this addressing the underutilization of curative options in pancreatic cancer. Indications for surgery. Once again, I would encourage you to look at the paper by Michael Trade. It gives in detail the indications for surgery, which I have listed here. I won't go over this in detail, other than to say that Whipple resection is indicated for benign and malignant lesions entrapping the lower end of the bile duct in the head of the pancreas. It is also important to know that this operation is indicated for trauma of the pancreas head and the duodenum. This trauma can be blunt trauma, it can be penetrating trauma, and in this day and age, believe me, ERCP or iatrogenic injury to this area of the anatomy is increasingly commonly encountered. The issue of centralization and high volume center. There is no consensus on what constitutes a high volume center. Some people say 3 Whipple resections a year is enough to call you a high volume center. Others say it has to be 30. When this concept was subjected to a real analysis, they found that a surgeon performing 2 or 2.5 Whipples a year achieves as good results as a so-called high volume center. Do outcomes define a high volume center? The only published outcome standard is a mortality of 4 to 6% at 30 days. Believe me, this can be achieved even outside a so-called high volume center where 30 or more Whipples are being performed every year. More recently, in the World Journal of Oncology in 2022, there was a very interesting article from the West Indies where in a small population, island-bound, unable to be referred to any high-volume center anywhere else, a group of surgeons achieved equivalent outcomes. And their contention is you don't need a high-volume center, you need an experienced surgeon. And the definition of an experienced surgeon is somebody who has got over the learning curve, and currently the learning curve is about 50 cases. Almost all the patients coming to a Whipple resection are jaundiced due to an obstruction of the lower end of the bile duct. It is today next to impossible to receive these patients for a surgical consult without them having had some form of biliary drainage preoperatively. There are two ways you can drain an obstructed bile duct. One is by ERCP with placement of a stent, and the other is by percutaneous transhepatic biliary drain, which is done by interventional radiologists. Be aware that randomized clinical trials have never proved that preoperative biliary drainage has improved mortality. What it does is to reduce the bilirubin. And this is done at the cost of introducing infection into the biliary tree. If the bile is drained efficiently by either ERCP and stent or by PTBD, then the infection introduced may not become invasive. But the fact is, you trade a sterile, obstructed biliary tree for an unobstructed but infected biliary tree. Remember also that these bugs have been introduced into the biliary tree in a hospital. They're likely to be multi-drug resistant. Use of imaging. Most patients who present to a primary care doctor or are seen in a gastroenterology clinic will get a CT scan of the abdomen. This CT scan is practically worthless for a surgeon. The only way you can get the information you need from a CT scan is to have a pancreas protocol CT scan, which involves injecting a large bolus of contrast up to 60 cc's, usually by a pressure injector, not by hand injection, and taking images of the pancreas in 3 phases: the non-contrast, the arterial phase, and the venous phase. This is how you will be able to get the information you need for encasement of vessels, presence of an aberrant right hepatic artery, and this is the only way you will know if the celiac artery and the superior mesenteric artery at the origin are not stenotic or have low flow in a patient who is older and may have atheroma and atherosclerosis of the entire abdominal aorta. It is also important in this CT scan to assess the fistula risk score. I will talk more about this later, but assessing the fistula risk and also assessing frailty by looking at psoas muscle volume are important things to pick up in the preoperative CT scan in a patient whom you're going to be taking to surgery. Most reports suggest an interval of between 30 and 60 days between diagnosis or presentation at a diagnostic center and surgery. These patients have 30 to 60 days that lapse between the time they are seen in clinic and the time they come to surgery. What happens, unfortunately, that these are 30 to 60 days wasted. This is the time you have to do what is called prehabilitation in the transplant literature. Why is prehabilitation important? It is important because you cannot take a patient safely to surgery who doesn't have good pulmonary function, good respiratory effort, and good skeletal muscle strength, legs and lungs. This is what you need to focus on along with nutrition during the time that a patient is waiting between diagnosis and surgery. It is not difficult to do. However, if you want to do it properly, it should be done with a dietitian, nutritionist, and a physiotherapist involved in this part of the management, because that is how you introduce professionalism into prehabilitation. Coming to cardiac and renal risk assessment. Believe me, cardiac assessment is no longer a problem. Almost never have I seen a cardiologist saying that a patient cannot undergo surgery, and almost all good anesthetists these days are able to manage a fairly significant cardiac risk. The problem comes if somebody has got critical ischemia and needs to have an angioplasty or stenting of some coronary vessel prior to surgery. You have to be sure that they don't put in drug-eluting stents and require antiplatelet management, because then you'll be doing a Whipple resection with somebody on antiplatelet drugs, either aspirin or Plavix, and that can be a daunting procedure. As regards renal risk, remember, these patients are badly nourished, they're dehydrated, their kidneys are suffering from the effects of long-standing diabetes, older age, and they've been given boatloads of contrast in the process of getting CT scans. There can be renal injury. In the past, operating on jaundiced patients, we knew that we create acute renal failure after operations. This is related to endotoxemia in patients with obstructive jaundice. I won't go into this more than to tell you that if you're interested in this topic, please Google limulus lysate assay and endotoxemia, how it is measured and how it can be mitigated by bowel preparation prior to surgery in somebody who is jaundiced. Putting in lines on these patients. I believe all the patients should have an arterial line and a central venous line. The reason is you can monitor arterial blood gases at regular intervals right through the operation, and you can use the central line to check the CVP and use these two to decide fluid management. A high lactate or a low CVP may be an indication to give more fluids to the patient. Regarding the incision, most of the time today, a midline incision is used for the open operation. I will not be discussing laparoscopy and robotic approaches to this surgery. In the open procedure, a midline incision stretching from the xiphoid down to the umbilicus, or maybe a little bit infraumbilical, is all that you require. Most of the important structures are midline structures. The vascular structures that you need to be careful about are all in the midline. Applying a subcostal incision, a bilateral subcostal incision, or a Mercedes incision, not a good idea. If your patient is very obese, I would say that the best incision is a Makuchi, which is a midline and a transverse right incision with application of the Thompson retractor, which is used commonly for liver surgery and liver transplant. If you stay with just the midline incision only, a Buckwalter retractor is also pretty good. The first step in any cancer operation is to assess resectability. It is always possible, despite the best preoperative investigations, to find that there are peritoneal mets or small liver metastases which could not be picked up by preoperative imaging. In this situation, you have to take a decision whether to proceed with a palliative Whipple if the tumor itself is resectable. This is perhaps a controversial area, but I think you can't provide better palliation than a good Whipple resection. So something to consider. Once you know that the patient is amenable to resection because the tumor is mobile and doesn't appear to have spread obviously into the surrounding vessels, you have to mobilize the duodenum. And a Coker maneuver is done, an extended Coker where you mobilize the duodenum until you can see and feel the aorta. And you can sample the lymph nodes which are present in the aortocaval groove. In order to access the hilum of the liver, you have to be able to rotate the liver by pulling the right side and the dome of the liver downwards while rotating segment 4 upwards, and I will show you how this is to be done by drawing it for you. At this point, it is important to open up Morrison's pouch, which is the space between the liver and the right kidney, and introduce your finger into the foramen of Winslow, where you can palpate the structures in the hilum of the liver, and you may be able to figure out if there is a replaced right hepatic artery or not. It is also important at this stage of the operation to mobilize the gallbladder, bring it down, maybe take it out, and encircle the common bile duct. This is what you see when you open the abdomen. The liver, the stomach, and the pancreas is lying behind the stomach with the spleen here. You can see the gallbladder, and remember, when you divide the falciform ligament, up here is going to be the IVC, and this line going from the IVC to the gallbladder is segment 4 of the liver. What is required is to bring the liver down and rotate it so that segment 4 goes up, because at the base of segment 4 are all the vital structures of the hilum of the liver. I will try and show you how that is to be done. Place lap sponges on top of the liver after you draw it down and apply a retractor to segment 4, pulling this upwards so that the gallbladder is exposed and the undersurface of the liver becomes obvious here with the bile ducts coming down, and you can see the undersurface of the liver rotated upwards. At this point, if you move your finger on the undersurface of the gallbladder and move it from right to left, you will enter foramen of Winslow. This is the point at which you will see the head of the pancreas and the duodenum and the stomach. Remember, the stomach has to be divided and retracted away, and then the underlying pancreas, the duodenum, and Morrison's pouch become clearly visible. Once again, retract the liver down, rotate segment 4 upwards, put the retractors in place, and put your finger in foramen of Winslow, check for a right hepatic artery, and now you're ready to proceed to resection and the supraduodenal dissection. Moving on to the operative steps. The supraduodenal dissection. Everybody doesn't call it the supraduodenal dissection, but I've tried to give it a name because it's a good idea that everybody in the operating room, your scrub techs, your nurses, your assistants, everyone knows the operation is in a certain phase of the operation. And the first phase is to do the dissection of the hepatic artery, ligate the gastroduodenal artery, and sample the hepatic artery nodes all the way down to the celiac artery as part of the supraduodenal dissection. At this point, you can divide the common bile duct, remove the smelly, stinky stents that have been placed in there, sample the bile for culture, and when you divide the bile duct and the gastroduodenal artery, you will see the portal vein lying below them. The first step in the resection is to do the supraduodenal dissection. What is required here is to divide the stomach at the junction of the pylorus and the antrum. Remember, the antrum is marked by the crow's foot, which is the termination of the nerves of lateral jet, and the pylorus is usually seen as a thickened muscle as well as the prepyloric vein. Once you divide this, you move the stomach away and you don't encounter it again. The colon is here. Some mobilization of the right hepatic flexure of the colon is necessary to move the colon down, and you have to dissect between the greater curve of the stomach and the transverse colon to separate the transverse colon and the stomach. After the stomach and the colon have been separated, you will see the head of the pancreas, the duodenum here, which has been divided, and you see the bile duct. You can put your finger in foramen of Winslow and get behind the hilar structures at this point. Now you have to start dissecting the hepatic artery. Remember, the hepatic artery runs on the surface of the pancreas and goes up to form the common hepatic artery and gives off the gastroduodenal branch. This gastroduodenal branch has to be divided, and you dissect along the common hepatic artery. As you go from here to here, you will invariably encounter a vein which sits here. This vein is a coronary vein. It is a companion vein to the left gastric artery. Despite its name, coronary vein, it's a completely useless vein. All that it does is to cause bleeding. You have to divide it carefully because it communicates with the portal vein. And if a ligature slips on this, it's like the portal vein bleeding out. There are always lymph nodes on top of the hepatic artery. These lymph nodes have to be removed and included in the specimen or sent for frozen section. Remember that the coronary vein lies above the point at which the splenic artery branches off from the common hepatic artery, and everything proximal to this is the celiac artery. So the celiac artery lymph nodes and the hepatic artery lymph nodes have to be sampled. The gastroduodenal has to be divided, and when you come into this space, the whole hepatic artery moves up and you're left with the bile duct. Once you divide the bile duct, and behind these two structures, you will see the portal vein, which is coming from here and going up to the liver. Portal vein is joined by the splenic vein and the superior mesenteric vein, and the many tributaries which enter the superior mesenteric vein at this point. The next phase of the operation is dissecting below the level of the duodenum. This is done basically to delineate and mobilize the superior mesenteric vein as it enters under the neck of the pancreas and joins the splenic vein to form the portal vein. How do you identify the superior mesenteric vein? Pull the transverse colon upwards. You will see the middle colic vein running down, and it joins the superior mesenteric vein just below the neck of the pancreas, and that's how you can identify the superior mesenteric vein and portal vein. The tributaries of the superior mesenteric vein are very fragile. You have to be careful when you divide them because the ties can break through the vein and cause bleeding. Bleeding in this area can be difficult to control, but it's not dangerous bleeding. It's just basically a nuisance. At this point, you have to go into the infracolic compartment, identify the duodenojejunal flexure, divide the ligament of Treitz, and divide the proximal jejunum. This has to be then taken deep to the superior mesenteric artery and vein and brought out onto the right side, a maneuver which is called derotation, restoring the original embryological situation so that the duodenum is now entirely being retracted towards the right side. At this point, you can divide the neck of the pancreas. Again, there is some bleeding, but this is not usually very dangerous bleeding when you divide the neck of the pancreas and expose the portal vein and the junction of the superior mesenteric and splenic vein. The last part of the resection is to divide the uncinate process. The uncinate process is the part of the pancreas that goes behind the superior mesenteric vein and the portal vein and is very close to the superior mesenteric artery. This is an area which will always have some bleeding. Some people like to put a vascular clamp, before they dissect the uncinate process nicely off the superior mesenteric artery, catching all the vessels that run from the pancreaticoduodenal branches into the uncinate process. Once the uncinate process has been divided, you remove the specimen and secure hemostasis meticulously all around the area. The next part of the dissection, which we can call the infraduodenal part, involves identifying the superior mesenteric vein just below the neck of the pancreas by tracing the middle colic vein down to it. Once you see this, you have a bunch of tributaries which need to be ligated, and you can come under the neck of the pancreas, separate the neck of the pancreas from the superior mesenteric vein. The duodenum comes like this, goes behind this, and has the ligament of Treitz tethering the duodenojejunal flexure here. This has to be divided, and this part of the duodenum rotated behind the superior mesenteric pedicle to the right side before dividing the neck of the pancreas. Once you divide the neck of the pancreas, you will see the pancreatic body with the dilated duct and the portal vein exposed. The duodenum is now being retracted to the right side, with this loop of jejunum having been brought behind the superior mesenteric pedicle towards the left side. At this point, you will see the uncinate process. After the first loop of jejunum has been brought behind the superior mesenteric pedicle towards the right side, is being retracted to the right, along with the head of the pancreas, which has been divided, being retracted towards the right, you will see the part of the pancreas that is closely applied to the superior mesenteric artery. This is the uncinate process, and it has many small branches coming from the pancreaticoduodenal artery of the superior mesenteric into the uncinate process, and these have to be carefully divided. This constitutes the last step in the resection, after which the head of the pancreas and the duodenum, the so-called pancreaticoduodenal specimen or the pancreaticoduodenectomy specimen, can be removed. Once the resection is complete, you now have to do the reconstruction. The usual sequence of the reconstruction is to first do the pancreaticojejunal anastomosis. The next is the biliary enteric anastomosis, and the third is the gastrojejunostomy. The loop of jejunum that has been divided is taken up into the supracolic compartment through a small opening in the transverse mesocolon, and the pancreaticojejunal and choledocojejunal anastomoses are completed in the supracolic compartment. After this, an opening is made to the left side of the middle colic vessels in the transverse mesocolon. The stomach is drawn down into the infracolic compartment, and the gastrojejunostomy is done. These three anastomoses together constitute the reconstruction following a Whipple resection. It is important to do the pancreaticojejunal anastomosis in this day and age using a mucosa to mucosa technique and incorporating a stent. It is very unusual in today's day and age to do a dunking procedure where the whole surface of the pancreas is dunked into or invaginated into the jejunum. This is only required in those rare cases where the pancreatic duct is either obliterated or is too small to do any kind of duct to mucosa anastomosis. Once the resection is done, what you have is the bile duct ligated, you have the pancreas divided, the stomach divided, and the jejunum. This has to be reconstructed. Typically, the reconstruction is done by pancreatico-jejunal anastomosis, incorporating a stent in the anastomosis which has been done with the mucosa of the duct to the mucosa of the jejunum. Distal to the pancreaticojejunostomy the choledochojejunostomy is performed. This loop is then brought into the infracolic compartment and the anastomosis performed. Pancreaticojejunostomy, choledochojejunostomy, and gastrojejunostomy. These two anastomoses are in the supracolic compartment and the gastrojejunostomy is in the infracolic compartment. This constitutes the reconstruction. Postoperative management strategy. Most of these patients have to be managed in an intensive care unit for the first 24 to 48 hours, and during this period, it may be necessary to electively ventilate some of these patients or routinely electively ventilate the patients until you get a set of labs, you fix everything before you wean off the ventilator and extubate them. The most important principle is to use IV fluids judiciously so that you prevent pancreatic edema. Remember, the pancreas gets only 5% of the cardiac output. It is supplied by small branches of arteries which are headed somewhere else, either the hepatic artery or the splenic artery or the superior mesenteric artery. There is no pancreatic artery. You only get small arteries supplying the pancreas. If you fluid overload the patient and have pancreatic edema, these small arteries have to pump into a high resistance field, can thrombose, and result in pancreatic necrosis and breakdown of the anastomosis. Antibiotics, usually required for about 48 hours, by which time the bile culture report will be available, which you drew during the surgery and you took out the stents from the bile duct. If it is positive, you have to give the appropriate antibiotics, preferably for 5 to 7 days. Nutrition. Remember that many of these patients are malnourished coming into the operation. You can assess the malnourishment by the level of albumin, prealbumin, and vitamin D, and you may have to make a decision before surgery to put in a feeding jejunostomy or to maintain them on TPN. The NG tube has to be placed as long as there is gastric atony. If there is no gastric atony, you can probably remove the NG tube in 24 hours. Drains, there are usually two drains, one in Morrison's pouch coming out on the right side and the other one anterior to the pancreaticojejunal anastomosis coming out on the left side. Management of these drains is very individualized. I personally feel that measuring drain and serum amylase starting on day one is a good way to make the management of drains objective and to know when to take them out. The sooner you remove the drains, the better for all concerned. Should the drains be put on suction or should they be put on gravity drainage? This is also an individual preference. Personally, I think gravity drainage is enough. To go on to the management of the number one killer complication of this operation, which is pancreatic fistula, also called postoperative pancreatic fistula or POPF, which is now kind of the accepted acronym for this complication. You manage this complication like you manage any other complication by being prepared for it. And the preparation for this should ideally be done before the patient is brought to the operating room. There is a very good article, which I have quoted here in the Journal of the American College of Surgeons, which describes the fistula risk score. It is also available online where you can just plug in the numbers and it'll spit out the score for you like you do many of the other scoring systems today. The principle behind the fistula risk score should be remembered. The patient who has a thick edematous, very parenchymatous pancreatic gland is more likely to leak. The patient who has a very small duct, pancreatic duct less than 3 millimeters, more likely to leak. A patient who has bled a lot during surgery and has had to have large volumes of blood and fluid products, more likely to leak. It is possible to do a Whipple resection without blood transfusion, and that should be the ideal that you aim for every time. However, a patient coming into surgery anemic, this may not be possible. What is large volume transfusion in these patients? The usual definition is transfusion of blood more than a liter, but I think anything more than 1 unit is probably a high volume of blood being transfused into these patients. What is not mentioned in the fistula risk score is the influence of body habitus. If you're doing a Whipple resection on somebody who is very obese, the pancreas and all the surrounding retroperitoneal tissues are more likely to go into some kind of necrosis if there is a small pancreatic leak, and pancreatic leaks in obese patients are more difficult to manage. The patient with the lowest risk of a pancreatic fistula post-surgery is the one who has either an atrophic or fibrotic pancreas with a large pancreatic duct. These are patients who are very unlikely to get a major pancreatic fistula post-Whipple resection. It may be a good idea for your first 50 or so Whipple resections to select patients who have a low fistula risk score. What can you do operatively in the operating room to manage a patient with a high risk of a pancreatic fistula? There are two ways. One is you decompress the loop, and there are different ways of doing that. And the other is a Brown anastomosis, which is what Michael Trede advocated. I will draw a diagram to show you both of these. The third option is to put an isolated loop to the pancreas. This option is also the best to manage a postoperative pancreatic fistula which requires reoperating. I will describe this in a hand drawing as well. This shows the reconstruction: pancreaticojejunostomy with the stent incorporated, choledochojejunostomy, the loop coming through the transverse mesocolon into the infracolic compartment, and the gastrojejunostomy. One of the problems is that in this area, the total amount of secretion can be to the tune of 6 liters a day. And all that volume, if it accumulates within this pancreaticobiliary loop, can result in distraction of all of these anastomoses. How have people tackled this? One of the ways is to decompress this loop with a tube to the exterior. So this is the abdominal wall. A tube can be placed in this loop and brought out of the abdomen. If the patient has a percutaneous transhepatic biliary drain established preoperatively, that decompression tube can come out of the abdominal wall above. That provides a very good decompression. Otherwise, a tube can be placed and brought out of the abdominal wall to decompress the pancreaticobiliary loop. It's important to remember, however, that these tubes have got side holes and an end hole, and usually only one or two of these holes really works. And this can be a very inefficient way of decompressing this loop. What Michael Trede has described is to perform a Brown anastomosis. In other words, you have the afferent loop of the gastrojejunostomy here, and you have the efferent loop here. You perform an anastomosis between these two. In other words, bring this loop like this and do the Brown anastomosis here. This Brown anastomosis will decompress the pancreaticobiliary loop beyond the level of the gastrojejunostomy into the jejunum. Remember that in case this patient has gastric atony and the stomach is not working well, the patient was malnourished preoperatively, you may have to put in a feeding jejunostomy into this efferent loop of the jejunum. These two methods to decompress the pancreaticobiliary loop may help to protect the pancreaticojejunal anastomosis, divert the secretions away from it, or prevent gastrojejunal stomal dysfunction with excessive collection of gastric and contents into the afferent loop and drain it into the efferent loop from the jejunum by means of a Brown anastomosis. The concept of isolated loop to the pancreas can be used in case the pancreas is very edematous and has such a small duct that a duct to mucosa anastomosis is going to be difficult, and you don't want the secretions which are present in this loop of intestine and of course the bile coming in to activate the pancreatic juice on the cut edge of the pancreas. In such patients, a biliary anastomosis can be done here, the gastrojejunostomy can be done here, and on the efferent loop from the GJ, you can divide it and take this distal loop up to the pancreas. And perform this jejunojejunostomy to this loop here. In this case, this segment of the intestine is completely separated from the biliary loop and from the stomach contents and provides an isolated loop to the pancreas with minimum risk of enteric contents activating the pancreatico-jejunal anastomosis. What do you do in a patient who has total disruption of the pancreatico-jejunal anastomosis? This can happen if there is bleeding in and around the pancreatic anastomosis. The blood will collect in Morrison's pouch and it can get infected, and this can lead gradually to disruption of the anastomosis. Sometimes the bleeding can be torrential and you have to take the patient back to the OR, in which case there are two areas to look for bleeding. One is a slippage of the tie around the gastroduodenal artery, which is right in front, easy to control, especially if you have left a stump so that you don't suture onto and narrow the hepatic artery when you control this bleeding. The other place from where you can get bleeding is from the superior mesenteric artery, and remember that this is sitting behind your anastomosis. So you will be distracting your pancreatico-jejunal anastomosis to identify the bleeder. Again, these bleeders are not very difficult to control, but the process of controlling them, pulling and pushing in the OR, especially when the patient is crashing, there is a big drama with everybody shouting, the anesthetist trying to reintubate the patient, pour in fluids, etc., can disrupt the pancreatico-jejunal anastomosis. How to manage a disrupted pancreatico-jejunal anastomosis? The most important thing is to debride the pancreas, remove all the dead tissue, necrotic tissue, and infected stuff around the anastomosis, divide the loop so that the segment of loop anastomosed to the pancreas is removed and excised. The choledochal anastomosis is retained. After this, you have to decide whether to drain the remnant of the pancreas externally, to do a total pancreatectomy, or to do an isolated loop to the pancreas. It is possible to initially drain the remnant of the pancreas externally by a placement of a tube into the pancreatic duct and go back later and do the pancreatico-jejunal anastomosis to an isolated loop. This is kind of like the original two-stage procedure which Alan Whipple had initially described for this operation. So if you have to do it, that's okay. External drainage of the pancreatic juice is not a crazy idea. Remember, these pancreatic enzymes that come out in the pancreatic juice are in the zymogen form. They are not active. They're not going to cause any necrosis or autodigestion of tissues in that area if you can achieve satisfactory external drainage and the pancreatic juice doesn't collect and form a big collection behind the stomach there. Remember though that some gram-negative infections can act like the enteric enzyme activators and activate the pancreatic juice. So a thorough debridement, removing all infected tissue and thoroughly irrigating the area to clean up the infection is the trick to achieving a controlled external pancreatic fistula. After such a redo operation, where you've had to disconnect the pancreatico-jejunal anastomosis, debride and resect the pancreas, and maybe provide an external drainage of the pancreatic juice, remember that the principles of management are the same as previously. Try and limit the IV fluids, run the patient as dry as possible, and get them off the ventilator as soon as possible. Nutrition is key. In these patients, it may be necessary to perform a feeding jejunostomy so that you can continue nutrition distal to the point at which the disruption and the leakage has happened. In conclusion, I would like to say that achieving a mortality of less than 5% at 30 days is an eminently achievable target. To achieve good outcomes, you have to have an experienced surgeon, preferably a high volume center with experienced surgeons and an experienced team by the anesthetists, the nurses, the nutritionists, the rehab people, the prehabilitation, the post-op management in the ICU. All of that is happening in a streamlined fashion is what constitutes a high volume center. Can you build a high volume center? Absolutely. Remember that the management of complexity does not require a very high IQ. It requires a good checklist. A good checklist to manage every phase of the complexity is key to management of complexity. The next most important thing in managing complexity is to create a core team and debrief every operation. I would suggest an occasion in which all members of the team, all the stakeholders get together, sit down over a meal, maybe a glass of wine, and decide everything that went right and everything that went left, so that you learn from every procedure. Lastly, the key component in a good team is a surgeon who brings everybody together. Remember, a disruptive surgeon can never have an experienced team for very long. As in the previous lectures, I would like to remind you all that the exam-oriented approach has to be initiated by you, the listeners. If you can send in questions which are of high value, there is a prize. Remember, collaborative learning rather than trying to be competitive is the way to go forward. I would sign off as usual by saying, travel together, travel long, and keep in touch.